Okay, let's dive into this. Welcome to today's Explainer. We're taking a deeply investigative look at the clinical realities of eating disorders. These are conditions that are so often misunderstood, heavily stigmatized, and frankly, they frequently go entirely unrecognized in clinical settings. Today, we're cutting through all that noise. We are going to break down the rigorous clinical protocols for how to approach diagnosis and management in detail, going step by step.
Let's start right here with an absolutely staggering statistic. Anorexia nervosa carries a 5% mortality rate for every decade of illness that's driven by starvation, suicide, and heart failure. I'm sharing this right off the bat because it really underscores the grave, literal life-or-death stakes of what we're discussing today. Proper diagnosis and immediate, effective management, they aren't just clinical guidelines, they are literally life-saving interventions.
So, here is our clinical roadmap for today. We're looking at the core shared psychopathology, diagnosing anorexia nervosa, managing anorexia nervosa, diagnosing bulimia nervosa, managing bulimia nervosa, and finally, recognizing other eating disorders.
Section 1. The core shared psychopathology.
Now, this concept is the root of the whole issue. Whether we're talking about anorexia or bulimia, they share a distinctive psychopathology, an extreme overvaluation of weight and shape. We aren't just talking about a desire to be thin here. We're talking about patients who judge their entire self-worth, their core value as a human being, almost exclusively by their shape, their weight, and their perceived ability to control those things. It is an intense, completely all-consuming cognitive distortion. Now, what's really interesting is that these clinical diagnoses, they're not always static boxes. Patients who meet the criteria for anorexia or bulimia frequently actually migrate between these categories over time. So a patient might present with restrictive behaviors one year and then binge-purging behaviors the next. This fluid nature is exactly why ongoing, careful clinical observation is absolutely crucial for proper management.
Moving to Section 2, diagnosing anorexia nervosa.
17.5. That is a paramount number. It is the strict body mass index, or BMI, threshold for suspecting anorexia nervosa. A BMI of less than 17.5, actively maintained by a severe restriction of energy intake, well, that's the absolute hallmark clinical sign we're looking for.
But, the diagnosis goes far beyond just a number on a scale. The body has this desperate narrative response to starvation and purging. You'll find hypotension and bradycardia, literally the heart physically slowing down just to conserve energy. You might see the growth of fine Landigu hair, peripheral edema, or eroded dental enamel and scarred hands. That's known as Russell sign, caused by frequent self-induced vomiting. And you really have to pay close attention to hypokalemia. That's dangerously low potassium. This specific electrolyte abnormality is a frequent sudden cause of death in these patients.
Taking all of that into account, the DSM-5 criteria require 3 strict pillars for an anorexia diagnosis. First, that very low body weight we just discussed. Second, an intense fear of gaining weight. And here's the brutal paradox clinicians have to recognize. That intense fear is almost never alleviated by actual weight loss. It just doesn't go away. And third, those overvalued ideas about shape and weight, causing a deeply disturbed self-evaluation, or a persistent lack of recognition of just how dangerously low their body weight actually is.
It's also super important to classify the specific behavior. Anorexia is split into 2 distinct subtypes. The restricting subtype involves pure caloric restriction without any binge eating or purging. The binge eating/purging subtype, on the other hand, involves regularly engaging in those exact behaviors while still maintaining that dangerously low BMI of under 17.5.
All right, Section 3, managing anorexia nervosa.
When a patient hits certain thresholds, we're looking at an absolute medical emergency. Hospitalization in a medical ward is mandatory if the BMI drops below 14, temperature falls below 35.5 Celsius, heart rate drops under 50, blood pressure crashes below 80/50, or if there are severe electrolyte disturbances. On the other hand, a patient requires a psychiatric ward admission for acute suicidal ideation, or if outpatient treatment has completely failed.
Let's move to and see how this builds into a highly structured, sequential treatment plan. Step 1 absolutely must be restoring weight. You simply cannot do effective psychotherapy on a starving brain, right? The target is a BMI over 18.5, increase slowly at about half a kilogram per week to avoid refeeding syndrome. Once they're stabilized, Step 2 involves psychiatric interventions like SSRIs or premeal anti-anxiety meds, and that finally paves the way for Step 3, targeted psychotherapy like cognitive behavioral therapy.
Section 4, diagnosing bulimia nervosa.
So, I pose this question to you. When should you actually suspect bulimia nervosa? If anorexia is defined by visible, severe weight loss, what are the clues for a disorder that is notoriously excellent at hiding in plain sight?
Well, the crucial point is this stark contrast in physical presentation. Unlike anorexia, a patient with bulimia nervosa usually has a completely normal BMI. They are essentially hiding a secret war. They suffer from a recurrent urge to overeat, but then they use extreme compensatory measures like self-induced vomiting or heavy laxative abuse to control their body weight. Because they look physically healthy to the untrained eye, bulimia often goes clinically unrecognized for years.
The DSM-5 outlines a very specific behavioral timeline here. It requires binge eating, unusually large amounts of food, accompanied by a terrifying sense of a lack of control. This is then followed by inappropriate compensation, which is driven by intense guilt. For a formal diagnosis, this vicious cycle has to occur at least once a week for 3 straight months. And this all happens while the patient suffers from those exact same overvalued ideas of shape and weight we saw in anorexia.
Section 5. Managing bulimia nervosa.
The management strategy for bulimia is highly specific. Psychotherapy, primarily CBT, is your frontline approach. Medically, antidepressants are remarkably effective here, specifically fluoxetine. It's often used at higher doses and it works rapidly to reduce those binge urges. But listen up, there is a massive clinical warning here. You absolutely must avoid the drug bupropion, as it can trigger seizures in purging patients. Furthermore, you have to treat associated disorders. Incredibly, borderline personality disorder is present in about 50% of bulimia cases.
And the data brilliantly illustrates the long-term reality of the disease. While it is a chronic and relapsing illness that gets exacerbated by stress, bulimia generally has a significantly better prognosis than anorexia. With proper targeted treatment and encouraging 50% of cases recover fully. Section 6. Recognizing other eating disorders.
First up is binge eating disorder. Now this looks very similar to bulimia at first glance. We're talking about eating excessive amounts of food in a discrete 2-hour period with a profound lack of control, happening at least once a week for 3 months. Patients eat rapidly, often alone due to embarrassment, and they feel intense disgust afterward. But here is the absolutely critical clinical difference. There are no compensatory behaviors following the eating. No vomiting, no laxatives, none of that.
Then we have pica. This involves the persistent eating of non-nutritional, non-food substances. Think dirt, ice, or paper. It's frequently seen in patients with intellectual disabilities, autism, or schizophrenia, and it has some really fascinating medical associations with pregnancy and severe iron deficiency. It's also worth just briefly mentioning that other conditions exist too, like avoidance/restrictive food intake disorder, which we usually see in kids, and psychogenic vomiting, which is chronic but notably not self-induced.
As we wrap up this explainer, I want to leave you with this final thought. We started by looking at a brutal reality, a 5% per decade mortality rate. These are not just phases, they are lethal psychiatric conditions. So given the tools we've uncovered today, from tracking heart rate drops to identifying hidden compensatory behaviors, how can we remain infinitely more vigilant in identifying these hidden signs before it's simply too late? Understanding the precise clinical reality of diagnosis and management in detail is the very first step to saving a life. Thanks for joining me on this deep dive.